Watch these videos and save a life. During this time, everyone must be ready to be a first responder. This video series guides you through the most common crisis scenarios and empowers you with the information you need to save a life. These videos can be used in real time or reviewed before use. We develop these videos for you and public safety professionals like medics, firefighters, hospital workers, and law enforcement officers. This video series has been designed by experts in medicine, public health, education, and communications. This gives people the best open access, trusted, ready to use information in an open access format. Watch these videos and save a life.
So I'm really excited to speak with you today about our work that's focused on empowering everybody with trusted, equitable, accessible, high quality health education. Our vision is that by 2026, we will have had views across the globe. We'll be working in multiple countries and generating videos that are relevant and culturally focused within various countries in those languages that are specific to those countries. And our target is to save lives through rapid, valuable education. For me, this journey really started around the Boston Marathon bombing in 2013, April 15, 2013. It's almost 10 years ago that this event occurred. If you remember, there were two improvised explosive devices that were set off near the Boston Marathon bombing, near the Boston Marathon finish line. And we had about 264 people that were injured, 4 lives that were lost. And I was the medical director for emergency preparedness and emergency medicine physician working that day. And what we did is pretty rapidly looked at and analyzed our response. And 29 individuals had lower extremity injuries on site. They were recognized as having lower extremity injuries, and almost every single one of them had tourniquets that were placed. Many of those tourniquets were placed by laypersons, and of course, the rest were played by emergency medical services or medics. And that really helped us understand that not only do people want to help, they will help and they will step up. And so a lot of our focus has been understanding how to empower the public with education so that they can intervene, understanding that time is so critical. On average, in the United States, it takes 7 minutes for emergency medical services to respond to an event. And people could bleed to death in that time frame. And in fact, trauma is the #1 killer for those under 45 years of age in the U.S. and is the #1 killer globally for our youth. So there are real opportunities to understand and improve trauma systems globally. In fact, the military has been really focused on reduction of preventable trauma deaths through their work, through 3 key interventions over 20 years of war in Iraq and Afghanistan. Their work focused on early care, so ensuring that patients were evacuated to a higher level trauma or hospital center within 1 hour. The second is a whole blood transfusion. And the third is pre-hospital bleeding control. So empowering not just medics or healthcare workers, but soldiers, sailors, airmen, and Marines on how to recognize life-threatening bleeding, apply pressure, pack a wound, or apply a tourniquet. Those 3 combined reduce preventable deaths on the battlefield by 44%. And so we recognize that, and through leaders here who started this work, Len Jacobs, who's a surgeon, Frank Butler, who pioneered this work on the battlefield in the early 90s through multiple iterations. Their teams were really leading this work to try to translate this into the civilian setting. So all those hard-earned lessons from the battlefield, the focus was, how do we decrease preventable trauma deaths back home? And so this campaign was called Stop the Bleed. It's a global campaign. I hope many of you have heard of it. There's been over 1 million civilians that have been trained across the globe in this work. And several campaigns really started to focus on this effort. And so there were several studies that asked, are people willing to help? This was a phone survey that Len Jacobs led, demonstrating that many individuals, the majority of individuals, would help a stranger, would help a family member during a variety of different scenarios. And my colleague, Craig Goolsby, who was at the Uniformed Services University, which is the U.S. military's medical school and health professions school, he started to do some work with developing tools around just in time. So having individuals that had no training, bringing them in and giving them a tool, whether that's a card or a color-coded tourniquet that guides you through application. And he had some early studies that demonstrated that that mechanism can be successful. And we asked the same question: can we train the public? How do we scale? How do we improve outcomes? And how do we make it reasonable? So we conducted the largest randomized control trial of bleeding control at the time. And to date, this is still the largest that's been completed around stop the bleed education. So we conducted this trial where we enrolled 465 individuals. We had over 500. We had to exclude approximately 100 because they had some form of prior medical training. And we randomized them into 4 arms. And in the first arm, all the way here to the left, the control, we walked people into a room. We observed them. We gave them a scenario. There was a mannequin there and an observer, and asked them to apply a tourniquet. And we observed them for the following objective measurements, which were location of the tourniquet placement, the amount of tension on the tourniquet, and how much time it took for them to apply the tourniquet. And so in that first arm, about 16% of people with no prior training got it right. In the second arm, they used flashcards, which are little cards that show a little diagram of how to place a tourniquet. About 20% got it right. And the third arm, they used a kit, which is a kit that looks like a defibrillator. You open it up, press a button, and it explains to you how to apply a tourniquet. About 23% got it right. And in the last arm, we evaluated the American College of Surgeons Basic Hemorrhage Control course, which is an hour-long course, half an hour of didactics, and half an hour of training, hands-on training. And so in the first hour, they took that course. In the second hour, we evaluated them, and 88% got it right. During that second hour, while this group was being evaluated, the first 3 groups then took the basic hemorrhage control course. And then we brought people back 3 to 9 months later and reevaluated them to see how much they retained, and about 54% retained that information. So on one hand, you could say, well, over 50% retained it. On the other hand, you could say only 50% retained it. So what we learned from this first exercise is these just-in-time tools were not particularly effective. There was no difference between not being trained. This course in an hour, you could train the public in 1 hour, and 88% of people, regardless of educational background, ethnicity, race, age, would get it right. And 3 to 9 months later, about 50% of people will retain that information. So this really pushed us to continue to think about just-in-time tools. Understanding retention is really challenging. This is a picture from, we conducted this study at Gillette Stadium, which is the home of a U.S. football team, the New England Patriots. And they were really just, and have been, an amazing supporter of our work. So here's one of the pictures from one of the trainings that we did. And not only did we do that, we also played a public safety announcement in the stadium. That public safety announcement was a video. This is one of the football players, and it would play for 30 seconds. And so that everybody in the stadium, about 68,000 people, would watch the video during the events, and it would guide you to a website so you could sign up for a class and learn about Stop the Bleed. So we also not only implemented this locally, but wrote about it and used a framework called the RE-AIM framework, Reach, Effectiveness, Adoption, Implementation, Maintenance, so that we essentially designed a toolkit so others can take the toolkit and apply it with any organization that they're in, whether it's a stadium, another venue, a school, or other places, a college, to learn about how to implement this type of training locally on a larger scale. We also looked at preventable deaths across the country and compared them similar to what the U.S. military had done overseas to understand where we could focus efforts. And again, this was a study led by my colleague, Craig Goolsby, really done some really impressive work of bringing people together and focusing on these efforts. And all the while, just-in-time tools were starting to spread. So this is an example of a company that's US-based called Mobilized Rescue Systems. They're now owned by Zoll, who does cardiac type monitors and AEDs and others. This was a device this was a kit. They also had an app-based version that you could use that prompts you on how to take care of medical emergencies. On the one on the right was a tool that was developed by Craig Goolsby at Uniformed Services University, again, thinking about ways to empower the public. And there were several trials that occurred in these. And then, we started to think about other ways to do this work.
Trauma is the leading cause of death.
And
under 45,
we did a video within our healthcare system to show how individuals can do bleeding control. The video, this first video was about 4 minutes long. And what you can see is we're starting to play with some things like text on screen. You see that it says your safety comes first to try to target multiple learners. We're trying to implement simple acronyms like ABC, alert, bleeding, compression, doing really focused and targeted education. So we started playing with video technology. We rolled this out to our healthcare system, which was at the time 2 hospitals, about 200 ambulatory clinics, and put kits throughout the organization next to all the defibrillators so that we were really implementing and scaling across the system. And so that was one of our first videos that we produced.
Unless you have extensive
and we also were learning about the different types of tourniquets that were out there on the market. There were many types. And what we didn't understand is how applicable the training was to the various types of tourniquets. So the challenge that we had is that as this campaign unfolded in the public, and there were many different vendors out there making tourniquets, if you put a kit in a location that has one type of tourniquet, let's say this orange one here that I'm pointing at, which is a stretch, wrap, and tuck, but an individual took the American College of Surgeons course and was trained on the combat application tourniquet, how effective would they be with another type of tourniquet? So we conducted another study. This was a crossover randomized controlled trial where we took 102 individuals, no prior medical training. We gave them the 1 hour long course, stop the bleed course, and then we randomized them to take and trial 5 different types of tourniquets. We measured the same 3 things: location, pressure or tension, and time. And what we found was with the combat application tourniquet, no surprise, pretty consistent, over 90% got it right. The soft T, which is a tourniquet that's this one here, which is very similar. It has a windlass, which is this rod, about 67% got it right. Then we looked at the stretch, wrap, and tuck, was about 11.8%, and the RAT, which is the rapid application tourniquet, were 11.8%, which are these 2. And so these skills don't really transfer unless you have a tourniquet that is very similar. The big surprise for us was actually improvised tourniquets. So we gave them a dowel, a rope, and some other equipment that you could use. And we found that about 1/3 of people were actually applied an effective tourniquet, and really around using and designing a mechanism. So that was a big surprise for us and really helped us understand where we could go. We also led a conference, which we teamed with Uniformed Services University at Brigham and Women's Hospital and Harvard Medical School, with about over 40 individuals from civilian, military, public health, emergency care, trauma, tech and innovation experts, to really think about what does a research agenda look like. And this was a 2-day event. We used a modified Delphi approach. We published this in JAMA Network Open. to understand and I'd prioritize research questions so that we could target where we want to head for the next decade with Stop the Bleed research. This was a recent study that we did, again, with Craig Goolsby, which was developing a novel audiovisual tourniquet, the LAVA TQ. It basically gives you prompts, and we compared it to individuals with no training applying the combat application tourniquet here to the left. What we found is using that LAVA TQ, it's 4 times as likely that someone will get it right. And you can see here 93% versus 22%. So pretty impressive. Again, sort of that just-in-time tool. You don't need any training. You just walk in, grab the tourniquet, and use it, and 93% chance you're going to get it right. So that LAVA TQ is really a recent innovation, and thinking about how you can scale that to both civilian and military use. The other thing that's really quite interesting is, of course, cardiac arrest, which is another significant healthcare challenge. We know that there are over 1,000 cardiac arrests per day in the United States. Only 100 of them survive, so 10% survival rate. And every minute of delay decreases your chance of survival by 10%. And in many cases, laypersons do not provide CPR. And in fact, it's less likely if you're a female, or less likely if you're Black or Hispanic to receive CPR. So there's some real challenges around this piece. Another public health crisis we face is the opioid dilemma. We've had, over 50,000 or so people die on an annual basis associated with opioid overdose. So there's some real potentially preventable deaths in this space. So we started to do some training. We rolled out initial training combining all of these: CPR, defibrillator, naloxone, which is a opioid reversal agent, and Stop the Bleed. And we started to pilot that program, survey, get some understanding how scalable it was. Lots of great participation. The challenge is it was quite long. We're talking about several hours. So again, this makes the argument for just-in-time training, because most people won't take that type of course because of the time limitations. And we recently did a study that's not published yet. It's under review, which looked at essentially when you ask voice assistants like Siri and Google Assistant and Alexa a question like, how do I perform CPR, what the response was. And what we found, essentially, if you see the yellow indicates that the response was did not know, the red was unrelated to CPR, and green is related to CPR. My colleague, Adam Landman, who is the Chief Information Officer here at our system, really led this work. And what we found was essentially that in many cases, the responses were not related to CPR and not effective. And if you think about how people practically do things today, in many cases, we're going to Google and doing a search. And so really leveraging and utilizing those search engines to pop up trusted, reliable, open access information that can teach people to do things just in time could certainly save lives. And that's been our focus. So at the outset of the current Ukraine war, I teamed with my colleague, Nelia Melnichek, who's a surgical oncologist. She's a Ukrainian American. We launched our first video together, and there were 2 videos. There was one that was 30 seconds and one that was about 4 minutes. We'll share those links with you. But we started to play in this video with different text on screen and other tools that we could use. And we launched this video. There's Dr. Melnichek. We launched this video in March with a small paid ad campaign targeting 4 cities in Ukraine. We used both Ukrainian and English. And what we found was a pretty good level of impressions and reach and views and through plays throughout that initial push. And so we started to team with others. We then subsequently did some work with YouTube and started to work on developing chemical, biological, radiological, nuclear videos. for the public. And again, we'll share those links that demonstrate how the public can identify chemical attack, for example, and what their initial steps could be, recognize, evacuate, decontaminate, and thinking of simple ways that individuals can take charge and help themselves and help others during these crises. And these are some screenshots from some of those videos demonstrating, for example, Narcan use, which is naloxone, an opioid reversal agent, atropine, which is used during a nerve agent attack, some guidelines around CBRNE, chemical, biological, radiological, nuclear, explosive readiness, in addition to things like scene safety here on the bottom right. So people in general had this toolkit of about 8 different videos. Half were for the public, half were for public safety professionals, firefighters, EMS, law enforcement, healthcare workers, to train each other. And then we partnered with a couple TV shows in the United States to develop another video. This was a Stop the Bleed video that was in Ukrainian. And that took off really in several parts. So they were really supportive. We had actors and actresses from 2 different US TV shows. And then in our latest effort, we've teamed with multiple organizations, us at Mass General Brigham, with all under the auspices of Harvard Humanitarian Initiative, with Boston Children's Hospital and International Medical Corps. In addition to Element, which is our production company, and GMKA, which is Nelia's nonprofit that she had started with a focus on educating Ukrainians. And this work is now live. We've partnered on developing 26 more videos, so now we have a total library of 36 videos. They're coming out. Some are online, some are coming out, and you can go essentially to our channel and then go directly to our playlist, which those links again will be shared with you so that you can watch these videos. These currently have titles in English, and we're getting those translated into Ukrainian. The videos themselves are all in Ukrainian with English subtitles. And it's really exciting to launch with these. It's another level of quality that's on display here with an embedded production company. They're all short. The goal is to have them 2 to 3 minutes long at most. There are a couple that are a bit longer. They cover 6 different domains: trauma care, like advanced trauma life support principles, trauma nursing principles, pre-hospital care principles, mass casualty management, which partners with the World Health Organization course, in addition to Stop the Bleed and a pediatrics course. So really a pretty robust curriculum. We continue to build these out, understanding that Ukraine is one nation that is undergoing a humanitarian crisis. But the reality is that humanitarian crises are occurring all over the globe in hotspots throughout Africa, Central America, South America, the Far East. Unfortunately, there are over 1 million indirect deaths associated with conflict annually. And so, and in many cases, accessibility is quite limited. And so we believe that developing these high quality, trusted, open access videos to reach some of those individuals that have previously been more unreachable can really help save lives. So we partnered with Ariadne Labs, which is a center that is based at Brigham Women's Hospital and the Harvard School of Public Health, to help scale this, to design, test, and spread this work. They really pioneered this type of Ariadne ARC with the World Health Organization Surgical Safety Checklist. Have done some amazing work, and so it's been a great partnership. This new effort is targeting 3 different regions over 3 years and developing 45 educational videos. And most importantly, not only are we developing these videos, but we really want to understand impact. So it's wonderful to get views and impressions and playthroughs, but we really want to take the next step, which is how do we understand, if I watch the video, did I perform that skill effectively? And what was the impact on the patient or the person that received the care from that video? And so working with experts in public health, medicine, technology, communications, social media, and others to really, and education to understand how we can trial some novel measures and develop those so we could set a standard within this space. And this is our new landing page with Ariadne Labs focused on our new campaign. And we just launched a new effort with the Clinton Global Initiative. They announced our effort in September at the annual conference, and we're working closely with them to help us connect with partners, to help us build this and scale this so we can continue this work. It's very exciting for all of us. And I'll just make one more quick comment. And that's, recently here in the United States, there was a cardiac arrest on Monday Night Football, which is, one of the most watched events during the week here in the United States. There was one of the football players who received CPR within 10 seconds. In fact, it's probably the safest place in the world to have a cardiac arrest. And the reality is most people don't have that accessibility. Most people don't have individuals standing by to perform CPR or use a defibrillator. And so that's why this type of education is so important to get out there to empower individuals with information to save lives. We're really excited about this work. It's been a really amazing team. I'm so thankful for everyone from each of these groups that's really stepped up, stepped in, and helped build these programs. And we're on the flight path and taking off, and look forward to following up with any of you who have any interest. Please reach out through any of the links that we share, and we're looking to scale and collaborate. So thank you for your time today.